Hello, my name is Mary Mitchell. I'm part of the AGACNP 2019 cohort, and this is my webcam presentation for the Fall 2019 Advanced Practice Clinical. History of present illness. This is a 78-year-old Hispanic male being transferred to the ICU for persistent hypotension. The patient was noted to have a systolic blood pressure in the 80s overnight, but this morning was noted to have a systolic blood pressure in the 60s. He was originally admitted for increasing shortness of breath over the past few weeks, and he was diagnosed with a CHF exacerbation, and his initial BNP was 13,390. His medical history is positive for restrictive systolic heart failure, and he had an EF of 30% on a previous echo with moderate to severe mitral regurg, coronary artery disease with a history of PCI and a CABG, chronic AFib and aflutter. He is on anticoagulation. Xarelto was his home med. Cardiac sarcoidosis, but the Remicade and prednisone had been discontinued for greater than a year due to persistent bacteremia. Hypothyroidism, hypertension, hyperlipidemia, diabetes, chronic kidney disease stage 3. His surgical history includes a BIVI-ICD that had been removed and replaced also for the recurrent bacteremia, CABG in the past, and history of cardiac ablations for the AFib. He does report a 5-year PAC history, but he quit smoking over 20 years ago. He does report occasionally having a drink at social events about once or twice a month, but denies any illicit drug use. As far as his family history goes, he said both of his parents had died at an old age in their late 80s. He is allergic to Benadryl. So subjectively, this was a pleasant 78-year-old gentleman. He was resting comfortably in bed. His abdomen did appear to be distended, and he appeared mildly short of breath. He did report that the shortness of breath has been increasing over the past 3 weeks, and it's worse with activity. And currently his daily activities are becoming difficult, if not impossible, to complete. He does report that his abdomen does feel distended, and he contributes that to his increased shortness of breath as well. He does deny any fever, chills, or palpitations, but he does also report a non-productive cough. Objectively, he is well nourished, but he does appear short of breath. He's oriented, no headache, no dizziness. He does have a grade 2 systolic murmur and +1 pulses to his radial and DP. He was on 4 liters nasal cannula, diminished breath sounds to his apices, and fine crackles noted to the basis. No wheezing was noted. Active bowel sounds. He did deny black or bloody stools, and he was not constipated, but he did feel distended. Denied any dysuria. He was able to move all extremities, no deficit there, and his skin was intact. He did also report, though, generalized weakness, but with testing his extremities, they were about a 4 out of 5 strength. Vitals, temperature was 98.2. Heart rate was 74, respiratory rate 19, blood pressure 76/54, and he was statting 96%. He had a VQ scan, and that did show an intermediate probability for PE to the right upper lobe, but bilateral lower extremity venous Dopplers were negative. He did have an abdominal ultrasound that was done that showed a small amount of ascites, but nothing that was able to be tapped. And chest x-ray did show pulmonary vascular congestion and a moderate right pleural effusion. WBCs were 14.2, BUN 32, creat 1.54, BNP 13,390. He did have 3 sets of cardiac enzymes, all were insignificant. Other thing, his INR was 5.43. So my differential diagnosis: hypotension, acute on chronic systolic heart failure, right upper lobe PE, shortness of breath, chronic AFib, A-flutter, and then he does have the history of cardiac sarcoidosis. So plan for him was to start him on a neosynephrine drip to keep his MAP greater than 65. We were going to hold all the antihypertensive meds and diuretics that he was on. He was currently, when he was on the floor before being transferred, he was on Coreg, Eldactone, IV Lasix, and Losartan. So we decided to hold all of those. He was on a heparin drip already, though, for the PE protocol, so we were going to continue that and continue holding the Xarelto. Echocardiogram with bubble study was ordered. Consult his cardiologist. Daily chest x-rays. Monitor vital signs per ICU protocol. His THS also was 8.73 on admission, so we were going to increase his home dose of levothyroxine up to 75 micrograms daily. Strict isonos, daily weights, cardiac diet, low salt, 1.5 liter fluid restriction. CT of the chest to evaluate the sarcoidosis, although the patient said it was localized solely to his heart. We want to make sure that it's not in his lungs. Consult nephrology, and then Protonix, 40 milligrams daily for him. Thank you.